Hello, I'm Molly Maassarani, and I'm a student on the Female Cancers SSM module at the moment. This is my presentation on the use of triple assessment in the diagnosis of breast cancer. The most common clinical presentation of breast cancer is a lump, however other features may also present. For example, skin tethering, nipple retraction, discharge, powder orange or lymphadenopathy, particularly in the axilla. Full assessment is required to determine whether this palpable mass is benign or malignant. Accurate diagnostic testing is essential in ensuring optimal management of the patient. Triple assessment was introduced in the UK in the late 1970s when fine needle aspiration cytology was added to clinical examination and mammography. Core needle biopsies started in the 1990s, and its multiple advantages led to this method rapidly being favoured over fine needle aspiration cytology. For example, its accuracy in the diagnosis of benign lesions, but mostly due to its capability of distinguishing between in situ lesions and invasive carcinomas. Today, the NICE guidelines recommend the use of triple assessment for all patients with symptoms that are suspicious of breast cancer once referred on the 2-week wait pathway to breast clinic. Parts of a triple assessment are history and clinical examination, imaging, and finally, a biopsy. So firstly, focusing on history and clinical examination, there will be many parts to include in a history from a patient. However, here we're just focusing on some of the most important parts. So you would first ask the patient their presenting symptoms, for example, site, duration, any other breast changes, and the relationship of their symptoms to the menstrual cycle. It's also to include any previous breast problems the patient may have had, as well as their hormonal history. For example, menstrual history, whether they are taking the oral contraceptive pill or hormonal replacement therapy, recent pregnancies, and breastfeeding. Some important risk factors would be family history of breast cancer or ovarian cancer, and any knowledge that the patient may have of genetic mutations in their family, for example, of the BRCA gene. For physical examination, you would be focusing on details of any breast changes the patient may be having. For example, the size, shape, consistency, mobility, tenderness, fixation, and position of a breast lump. Imaging can give a range of conclusions, for example, normal, benign, intermediate, suspicious, and malignant. Imaging for a cancer diagnosis requires ultrasound and mammogram, in contrast to screening where only one method may be used based on the patient's age. Ultrasound assesses the lump and guides the biopsy. It's also useful in distinguishing between solid lumps such as fibroadenomas or cancer and cystic lumps. In suspected breast cancer cases, the axilla may also be assessed for any abnormal lymph nodes. Ultrasounds are typically used in younger women since their breasts are more dense. Mammograms can detect calcifications that may be missed by ultrasound, and they are also useful in determining whether the breast cancer is unifocal or multifocal. Mammogram generally are more effective in older women and are used in screening in women that are over the age of 40. Standard views of a mammogram are oblique and craniocaudal. MRIs may be used to further assess the tumour in certain cases, but are not recommended as a diagnostic test in women at average risk. Only in very specific scenarios are MRIs added to triple assessment, for example, in higher risk patients, like those with a strong family history of breast cancer. So for biopsy, we'll first focus on fine needle aspiration cytology, which is where a thin needle is used to extract a sample of cells from the breast lump. Rarely, local anaesthetic is needed. Core needle biopsies is where a sample of tissue is removed from the breast lump under local anaesthetic. Core biopsies are done using a spring-loaded core biopsy device. Core needle biopsies give a more detailed information on the breast changes. Fine needle aspiration cytology gives you cell morphology, so you can only say whether there are malignant cells in the breast lump. Whereas because core biopsy removes breast tissue, the cytology can distinguish between invasive or in situ carcinomas. Immunochemical studies can also be conducted where proteins such as estrogen receptor and human epidermal receptor 2 can be measured. These are important in deciding on treatment and determining the prognosis of a patient's breast cancer. Both types of biopsy are usually done under guidance of imaging, mainly ultrasound, and very rarely an open surgical biopsy could be done if a diagnosis can still not be determined from fine needle aspiration cytology or a core needle biopsy. So we'll now look into the way that triple assessment is used in practice. Evidence shows that triple assessment is more accurate in detecting cancer than using individual components alone. The sensitivity of triple assessment is 99.6%, meaning that when used appropriately, cancer will be detected in 99.6% of women with breast cancer. Women with an abnormal result, for example, intermediate, suspicious, or malignant, obtained from any component of the triple assessment will need further investigation. Positive triple assessment will be referred to the breast surgeon for surgery. The type of surgery will be different between patients dependent on tumour size and breast size. A sentinel node biopsy may be done or full axillary node clearance as well. Radiotherapy, chemotherapy, and hormone treatment may also be considered. When all three components are negative, further investigation is usually not required because there is sufficient evidence that the breast cancer is unlikely with a probability of less than 1%. Only when symptoms persist or there are risk factors such as a strong family history, a specialist opinion may be warranted. CT scans, chest x-rays, and liver ultrasounds may be needed to check whether the cancer has spread to other parts of the body. An important part of breast cancer management in the UK is screening programmes. The NHS breast screening programme invites all women from the ages of 50 to 70 for breast screening every 3 years. There is current evidence that suggests that breast screening reduces the number of deaths from breast cancer by about 1,300 a year in the UK. You can have screening from a younger age if you have a higher than average risk of breast cancer. This may be due to a strong family history or an inherited mutated gene. Even with screening programs and effective diagnosis with triple assessment, it is very important to create awareness of breast cancer and the importance of women checking their breasts regularly. Here are some references from the information that I've included in my presentation. Thank you very much for listening. I would now leave a few moments for questions. Thank you very much.